Good morning, and thank you so much for the invitation to join you. I'm sorry I missed yesterday, but it sounded like there's been some great conversations here. And I am also the token Canadian on the panel, so I hope you will be forgiving and welcoming. And at the same time, too, I think we're in the midst of a journey here, which is we're still in the throes of it. And I don't know that we have full insight about where we are on that journey yet, but I'll try to share some of what we've learned, give you a little bit of context for what we're doing and where we're going, and let you know a little bit more about some of the current thinking and the current steps that are being taken in relation to data collection and monitoring. One of the things that as I was preparing these slides that really became clear to me is how important context is. Context insofar as the history of the society or the community that's coming together to be able to make such policy choices, some of the values that may be in place, some of the structures, some of the preceding policy decisions that create a setting within which certain possibilities are open and where other ones are closed. And I think this may become quite sharp by having both someone from the Netherlands and someone from Canada reflecting back on this. So what I'm going to be presenting is not something that is any proposal like a translation into another context, but rather to tell a story about a context and our Canadian journey to this point. So every one of these journeys, I think, has its starting point. And in Canada, it really started with, in 1993, when Sue Rodriguez, a woman in her early 40s with ALS, sought to see an amendment to the criminal code permitting her to have a physician assist her to die. And then, 20 some years later, in 2015, we have what is called there was the Carter v. Canada ruling, which is a story about Kay Carter, who in fact died in 2010. She, in her 80s, had spinal stenosis, went to Switzerland in order to have an assisted death. And it was her family, together with the British Columbia Civil Liberties Association, and another woman, Gloria Taylor, who actually made the case that subsequently went to the Supreme Court of Canada, and has hence opened up the opportunity for people, if they so chose, to have an assisted death. So that's a pretty big timeline. That's 22 years plus, where this has been in conversation at high levels, at a level of consciousness within the Canadian setting, and yet it has taken 22 years for there to be any formalization in law. And I think it's important to note this. So here's our Supreme Court of Canada that in 1993, the ruling at the Supreme Court of Canada was 5-4 against an amendment to the criminal code provisions related to assisting in abetting someone's death. In 2015, the court as a whole ruled unanimously, and I think the significant thing here too is that the ruling was on behalf of the court. There was not a matter of a judicial opinion. And so that's a pretty dramatic change. So you might ask, so what changed during that time? And I've been thinking about this quite a bit lately, and a few things stand out. Actually, that's... Okay, sorry, just to point out that in June 2016, we then had a new law in Canada that did lead to an amendment to the criminal code. I'll come back to that in a moment. So what changed? Well, their public perspectives changed over a period of time, and certainly around the time of the Carter decision. A number of public opinion polls were conducted, and whatever one might think of public opinion polls, there seemed to be a convergence around these polls, about 75% support for the legalization of medically assisted death in Canada. There was also, 22 years after the Rodriguez decision, there was more experience to draw from internationally. Certainly looking, somebody mentioned recently, Oregon sometimes treated it as its own country in the midst of this. Well, it's because it was out the gate. We've learned from, and I think we've benefited tremendously from learning from the Oregon experience, but also from the Benelux countries as well, which was noted by the courts at the time that there was experience to be able to demonstrate that a regime could be introduced that might alleviate some of the concerns related to medically assisted death that had originally been flagged in 1993. In 2014, province of Quebec rather, in Canada had introduced its own provincially led comprehensive integrated legislation related to end-of-life care, which introduced not only a right to palliative care, but also a right to what they called a medical aid in dying. And so we had watched this over a number of years. They had gone through 5 years of consultation with their residents to craft, through an iterative process, what subsequently became this piece of legislation. So in Canada, we were starting to see there were some lessons to be learned in terms of the thinking process associated with what legislation might be. And then finally, there were some shifts in terms of clinical perspectives. This is a photograph. The gentleman in this picture is Donald Lowe. So any of you who might recall in 2003 when SARS woke us all up to the fact that we really needed to invest more heavily in public health, Donald Lowe was the voice of a physician voice at that time, helping to raise the call about the need for greater public health investment. And at the end of his life, with an incurable cancer, he created a video about a week or so, and that's his wife, before his death to say, look, we need to reopen this conversation about assisted dying in Canada. And so there was, the Canadian Medical Association has been surveying its members over a long period of time. There have also been a number of studies that were showing that whilst there was support for legalization often, there was reticence to be a provider. And so there was a conversation happening within the clinical and the medical community in particular that was starting to help feed some of the thinking that was going on. So there were a number of factors that might have contributed to explaining why 22 years later Canada introduced medically assisted dying as an amendment to the criminal code. And I think it'll take us more time to really deeply understand some of those factors. But the other important piece about the Canadian context that's worth pointing out is that criminal code amendments are a federal jurisdiction, but health is primarily a provincial and a territorial jurisdiction. So this created an interesting conundrum, a legal conundrum, but also conundrum about the proper division of powers. So if Canada were to introduce legislation at the federal perspective, it would need to be translated in some way into the provincial and territorial practices, their own regulations in a way that had coherence. Canada also, by virtue of its diverse provinces and territories, has as many different diverse ways of organizing health systems. So that diversity means that if you look across the province, you do see some heterogeneity in terms of how they are organizing themselves around providing medically assisted death to their residents. And then finally, geography. We learned this firsthand from the territories in the north, who underlined for us that, look, it's not physicians who are primary caregivers. It is nurse practitioners. And so if we're going to take seriously the possibility of implementing medically assisted death in Canada, we need to take into consideration these different dimensions of diversity geographically and also different jurisdictions as well. And so that was an eye-opener. Coming from Toronto, biggest city in Canada, you don't really think about what's going on in the north until it's put before you. And you realize that we need to get out of our urban settings to think more broadly. So just to give you a sense of where we're at then in terms of medical assistance in dying in Canada. It is comprehensive of both. The Criminal Code Amendment actually provides protections for both physicians and nurse practitioners where in their province or territory where they're practicing, a nurse practitioner has his or her scope of practice includes similar procedures, for example, such as medication practices. It is permissive in terms of both clinician-administered and self-administered, and I'll come back to that in just a moment. In order for an individual to be eligible for medically assisted death, that person must be an adult over the age of 18. And must be capable of making their own decisions related to health. And indeed, there's another provision there that one must actually be legally eligible for health care in Canada as well. So this is not opening the door to anybody who should wish to knock on come across our borders and seek a medically assisted death. that the individuals must have a grievous and irremediable medical condition. I'll come back to that in a moment. Their request must be voluntary, and importantly, must not be with no evidence of coercion, and that it must be informed. And informed, not consensual, but informed of the available options that they may have. Now, the grievous and irremediable medical condition is one that has been a bit of a challenge for us to interpret what it means. Grievous and irremediable is quite comfortable in a legal context, but many clinicians struggle with this. But just to provide you with a sense of what this means in the Canadian context, it would be, and all of these criteria must be met. It is a medical condition, disease, illness, or disability which is serious and incurable. It's in an advanced state of irreversible decline in capability. The individual must be experiencing enduring physical or psychological suffering that is intolerable to them, and that cannot be addressed by means acceptable to them, and that in the case where the individual's natural death is reasonably foreseeable under these circumstances. Okay, so quite a bit of ongoing controversy about how to put some of these things in practice. And then finally, the bill actually, the amendment also lays out a number of procedural requirements, including requirements related to the nature of the request, how the request is conducted, how it's signed, how it's witnessed, and also recognizing not everybody may be able to write a request, other provisions and other terms of other ways to communicate that request. Assessment by 2 independent practitioners, confirming the eligibility and confirming the nature of the request. There need to be 10 what are called clear days between the request and the actual revision, with a further provision that this could be expedited in the case of imminent death or imminent loss of competence, and that the consent must be provided immediately before provision. Indeed, what I would characterize this as a real attempt within an act of legislation and a particular policy in trying to balance respecting autonomy, addressing suffering, and protecting the vulnerable, with a very strong lean towards respecting autonomy and with the procedural safeguards to being attuned to protection of the vulnerable. So our current experience is as follows: less than 1% since June, since the amendment was converted into law, have less than 1% of Canadian deaths are as a result of medically assisted death. The vast majority, with a number of exceptions I can count on one hand, are clinician administered, predominantly physician, a small handful which are nurse practitioner administered. The average age is 73, with a bulk, and this is the interesting comparison with some of the other findings, that is really phase shifted towards 55 plus. And sort of that cohort, these are not younger people typically who are asking for this, although the range is from 18 to 102, I believe. Medical conditions, as we've seen in other jurisdictions, focusing on primarily cancer, some the next then being neurodegenerative, circulatory, and other causes. And most, at this time, are being provided in hospital settings. But we're starting to see some movement toward in wherever someone lives, which could be their private residence, it could be a hospice, it could be a long-term care facility, and also initially, it was predominantly in urban settings, and now that is starting to move out much more widely. Again, thinking about the geography of Canada, that if this were primarily located in urban settings, that might be particularly concerning in terms of access. So what are we doing in relation to data collection and monitoring? The Bill C-14, which introduced the legislation into Canada, has requirements in it that the Minister of Health, the Federal Minister of Health, was to work with the provinces and territories to come up with a regulatory regime and to study a requirement to study the legislation 5 years from now. And so there is a review process that will be taking place. But some of what's happened so far is the federal government, Health Canada, has issued guidelines on death certificates with the goal of ensuring some consistency across the country and how those are actually, how medically assisted deaths are actually reported. And they're in the process right now working with the provinces and the territories on developing regulations regarding monitoring. In the provinces and territories themselves, they've also been actively involved in developing measures to monitor compliance in their own settings, and some are actually able to track other indicators perhaps related to access, indicators related to numbers of requests and types of requests that are being made, and reasons for why requests are not being granted. And then even at the local and institutional level, there's some variation there too. So again, this is not well knit together at this point, but there are conversations and efforts in place to try to begin to knit these together. Some of the pragmatic concerns and considerations that have been raised through the consultation the federal government has done with a range of stakeholders is concerns about burden on practitioners who are engaged in the reporting requirements, which is a very thorough process right through to the end, from the request into the provision of medical assistance in dying. Concerns about ensuring protection of the privacy of patients, practitioners, and pharmacists as well, who actually dispense the medication, the drugs. Ensuring clarity about reporting requirements. Of course, for many physicians and nurse practitioners, there's a sense of legal risk, and they really want to understand. So what are the requirements? How do I best meet those? An interest in identifying collectively a set of minimum indicators that we could use across the country for the purposes of comparison and for shared learning, and then aligning of these timelines, whatever the timelines for reporting might be, with the realities of clinical practice. Initially, the initial set of recommended or draft guidelines came out as 10 days, sort of after the request, 10 days afterwards, the physician or nurse practitioner must report, and the feedback they got was, look, the process is a little iterative, and so now they're proposing more like 30 days. So I think, again, it's a work in progress. And I'll end here. But what has surfaced through this is that monitoring for compliance is one piece of this, but there's a real interest in better understanding what data matters and which data matters. Data related to the quality of end-of-life care that's being provided that doesn't parcel off medical assistance in dying over here, but sees it potentially as an ongoing conversation patients, families, and their providers might have about what quality end-of-life might be that could lead to subsequently a request for medically assisted death, but really sharpening thinking about quality, sharpening thinking about how we would demonstrate that there is not only access to medically assisted death and that it is equitable, but that it is access to those other supports that we've heard about this morning, about palliative care, but other types of supports to ensure that in fact these are voluntary and informed choices that people are making. Concerns also about broader societal impact. In Canada right now, we're grappling with not only, as you are, with the opioid crisis, but also with youth suicide in the north, which is so a real push around suicide prevention. So how do these policy conversations sort of support some of the broader societal conversation we need to have about what a good society might be? Patient, provider, or public's perspective. Right now, it's really a government and a private provider perspective. Patient perspective might say, well, it's the experience. It's knowing my family is okay after this. The handoff is okay. So we really need to be thinking about those. And then finally, governments and regulators are engaged, but I want to lend my voice to others in saying we need to get the research community, that we've got research mobilization, but we need support from funders to ensure that we're systematically moving a research agenda forward that is indeed in the public interest, as researchers ought to be, but really leveraging that expertise so that we can really do this well. And I mean comprehensively well, the continuum of end-of-life care, not just simply medical assistance in dying. So I'll just leave it there, and I took a little bit more time because of the context, but thank you very much.